Welcome, everyone. We'll start the webinar in about 1 minute. Just give it a few more seconds while everyone comes in from the virtual waiting room. Okay, so let's get started. So welcome everyone to the Leukemia and Lymphoma Society of Canada's webcast called New Frontiers and Emerging Treatments for CLL. Today, Dr. Versha Banerji, a Canadian leader in CLL treatment and research, will provide the latest in the diagnosis and treatment of CLL. She will speak about who the disease affects and how it progresses, how decisions are made about when to treat, and the factors that influence the choice of treatment, promising new treatments being studied in clinical trials, and what the future holds for those affected by CLL. So let me introduce myself. My name is Sonia Muro, and I'm the Community Program Coordinator at the LLSC. I will be the host of this online event. The presentation will last approximately 60 minutes and will include a question and answer period at the end. Since there are many of you, we invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of your questions out loud at the end of the presentation during the question and answer period. The conference will also be recorded, so therefore you can listen to it again on our website. Before we begin our main presentation, I would like to share with you our mission and highlight some resources that might be helpful to you or someone you may know. Next slide, please. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer guidance and support every step of the way. We know the current situation presents many challenges to those affected by blood cancers. The community services managers can help. They are compassionate connectors that can help you cope with your blood cancer experience. So please do not hesitate to contact a community services manager in your area. Next slide, please. So this November, we launched our brand new website, bloodcancers.ca. On our website, you will find a variety of educational resources and support services. For example, you can find free booklets and fact sheets containing information about specific blood cancers, treatments, and practical information. You can also find animated educational videos, past webinar recordings, as well as access to our podcasts. Next slide, please. Our peer support program is a support service that matches people affected by a blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by a blood cancer and share similar experiences. So whenever possible, participants and volunteers are matched based on their age, gender, and diagnosis, or the issue that is most concerning. Be sure to contact the community services manager in your region to learn more. Next slide, please. CLL Facebook support group is a Canadian community for individuals living with CLL, the families of those affected, and for professionals also working with CLL. It is a place to share experiences and a place to inspire and encourage others also affected by the disease. So please be sure to check out our Facebook page. Next slide, please. And so it is now my pleasure to introduce our speaker today, Dr. Versha Banerji. Dr. Banerji obtained her MD and residency training in internal medicine and hematology at the University of Manitoba. She then completed a postdoctoral fellowship in translational research at the Harvard Cancer Center, Dana-Farber Cancer Center Institute, and Broad Institute of MIT. She's a senior scientist at the Cancer Care Manitoba Research Institute, associate professor at the University of Manitoba, and a clinician scientist at Cancer Care Manitoba. She co-leads the CLL clinic and is involved in several clinical trials and population-based treatment studies. As co-chair of the CLL research program, she manages a multidisciplinary research team in clinical, fundamental, and translational research. Her own laboratory is evaluating mitochondrial bioenergetics and function as a measure of cancer cell metabolism. So over to you, Dr. Banerji.
Thank you very much, Sonia. I'd like to thank everybody for the opportunity to speak today and to connect with all of you. These are my disclosures. I receive research funding from multiple national organizations and pharmaceutical industries, and I serve as a consultant to try and bring new treatments to my patients. So today we'll go through the definition of CLL and its counterparts, who it affects, when to treat, and what to treat with, and how are those decisions made. So I do want to open with this lovely image of the Museum of Human Rights. This is called the Tower of Hope. And what I do want to send home as the take-home message today is that we're in an era where we have multiple options for our patients with CLL or small lymphocytic lymphoma and chronic lymphocytic leukemia. And we want to make sure that you feel that you have a lot of options moving forward. So before we start talking about a disease state, it's always important to understand normal blood production. And so what is important is when we look at the development of blood cells, usually they arise from a single cell known as a stem cell, and then they start to divide based on signals to their cell type that really makes up the factory that is known as the bone marrow for blood production. And so I talk about the bone marrow as a symphony with my patients, and all of these different cells represent different sections that really have to work in harmony together. And so when we talk about chronic lymphocytic leukemia, we're talking about cells that arise from the B lymphocyte. And so when we look under the microscope, this is what normal blood looks like. You have your red cells, you have white blood cells, the lymphocyte. A neutrophil is often talked about when we talk about effects of different treatments, and platelets. And what you can see here is that there's very few white blood cells, a few platelets, and a lot of red cells. And that's what a normal blood picture looks like. In patients with chronic lymphocytic leukemia, the picture changes. And what we see is an increase in the number of what we call clonal white blood cells, known as lymphocytes or clonal lymphocytes, in the peripheral blood. And that's typically how patients are often diagnosed, with an abnormal blood test for routine testing for multiple different conditions that they may already be followed for, or just a routine clinical exam with their family care provider. And so we now have definitions of a spectrum of lymphoproliferative disorders. So these arise from a clonal B cell, and clonal means that they wear a specific uniform. And in CLL, that's by different surface markers seen here. And so we have a spectrum of disorders. One is known as monoclonal B cell lymphocytosis, then CLL, which is chronic lymphocytic leukemia, and followed by small lymphocytic lymphoma. And someone can be diagnosed at any point in this journey, and people can transition between one or another as well. And so what we're looking at is a threshold that needs to be achieved to meet the diagnosis of chronic lymphocytic leukemia. And that is 5 uniform cells within the peripheral blood. And so that is a special calculation that needs to be done. A lot of people might be diagnosed quite early, and they may not have any abnormalities in their other blood counts, or any lumps or bumps on physical examination or CT scans. And those patients are diagnosed with monoclonal B cell lymphocytosis. Small lymphocytic lymphoma and CLL are very much parallel conditions. And usually it's the fact that the patients with small lymphocytic lymphoma don't have a high number of these clonal cells in their bloodstream, but they do have lymph nodes or have these cells within their bone marrow space. So who does this condition affect? There's about 2,600 new patients diagnosed in Canada each year, and the average age of onset is 72. So it tends to be more common in men than women, and there's no known cause that we have identified at this time. It's considered an incurable cancer or a chronic cancer, and is observed for a period of time and is treated at the time of disease progression or symptoms. And the reason for this is mainly because we haven't demonstrated that early intervention benefits patients, but this is continuously being evaluated as new treatments develop. And some of the ways that we can determine who needs to be treated versus who is better served observed is with the use of prognostic markers. So the common presentations that we see of our patients is that they're often feeling well, and they either have an abnormal finding on a physical examination, such as the development of new lymph nodes, or a routine blood test by their family doctors or nurse practitioners or physician assistants, whoever is involved in their care. But over time, they may develop symptoms that become concerning for progressive cancer or typical cancer symptoms known as B symptoms. This is fevers, chills, night sweats, when a patient does not have a respiratory illness or an infection, weight loss greater than 10% in a very short period of time, and loss of appetite or nausea or vomiting. They also may develop changes in their physical examination, so lumps or bumps within the neck, the groin, or the underarms, which are known as lymphadenopathy, or a big spleen, and that might cause some discomfort within the belly or the abdomen. The other thing we note with patients with CLL, SLL, or MBL is actually the development of infections over time. And this is because of the impact these abnormal cells have on the immune system. And because of this, we very much recognize the risk of increased infections, specifically viral infections in patients. And as a result, patients may develop colds and coughs, and they may not resolve as quickly as they used to in the past. And so the other role that the immune system plays is actually in safeguarding patients from second cancers. And so the other thing that happens with patients who get diagnosed with CLL is that they may be actually being worked up for another cancer, and they get diagnosed with two different conditions at the same time. The other common cancer that is associated with these conditions are skin cancers. So a lot of people ask about their staging when they come to see me. And so today I'll concentrate on the staging for chronic lymphocytic leukemia. And that what we use in North America known as the RAI staging system. So patients who have an abnormal number of white blood cells in the peripheral bloodstream alone are considered to be at RAI stage 0. If you have lymphadenopathy or lymph nodes that are present, then it would be RAI stage 1. If we can feel your spleen, it's RAI stage 2. And then we look at the blood counts. So what I have here is a picture what the normal bone marrow looks like. And you can see there's a lot of empty space and space occupied by blood production. But what happens over time is you have an increased number of these white blood cells in that factory. And so you can see here the symphony is well balanced. You have a good distribution of everything. Akin the white blood cells that are growing as the trumpet section. And what's happening here is the trumpet section is getting louder and louder, and it's drowning out the other blood cells like the red cells and the platelets. And so we have RAI stage 3 is a hemoglobin or a red cell indicator of less than 110, and a low platelet count of less than 100 would be RAI stage 4. So it's due to the fact that the bone marrow is now affected by these cells to a significant degree that it's impairing the other normal blood production. And the reason why this staging system is important is that it helps us to predict how patients do over time. Now, we need to make the caveat here is a lot of these survival information were developed in a time when we were using older chemotherapeutic agents as our treatments. And a lot of this has changed drastically with the use of new treatments. But patients who have early stage disease tend to have better survival than those who have later stage disease. So what are the indications to treat? So progressive symptoms that I talked about, the hemoglobin and platelet markers of advanced stage disease. Large lymph nodes or bulky lymph nodes, as they are called, or a spleen causing symptoms, aches, pains, are also an indication to treat. Sometimes we look at how quickly the blood counts are changing and if they're causing the blood counts to change with them, the normal blood counts, the hemoglobin and platelets. So those are often reasons why someone might be treated early. And then the other thing is recurrent severe infections. So if people become hospitalized and their CLL is progressing, these two things can be related. And so to try and reset the immune system, getting patients' CLL under control may also be beneficial. So there's a lot of prognostic markers that are listed in lots of different research studies and in the textbooks describing CLL, but there are some that are really important, not only to predict how people might do over time, but also to inform treatment. And so the ones that we really use in the clinical realm from a clinical standpoint of view are the beta-2 microglobulin and some of these molecular changes or cytogenetic abnormalities that might help predict outcomes. So how do we evaluate some of these genetic abnormalities or molecular risk factors for your CLL? So there's a couple of tests that we'll talk about. One is known as FISH, or Florescence in Situ Hybridization. And basically what I have here is a picture of the nucleus of the cell that's composed of the genetic material. That genetic material is known as chromosomes, and on those chromosomes live genes that basically create proteins that are important for cell survival. And so what the FISH studies do is look at common chromosomal abnormalities that are a result of either loss of certain segments of the chromosomes or increased number of copies of specific chromosomes. And that can help us understand the genetic makeup of one CLL. So about 80% of patients will have at least one abnormality when we do a FISH test. And the reason this is important is because some of those abnormalities might be important for the regulation of the growth of a CLL cell. So if we think of a car, it has a brake and it has an accelerator. And so if we look at some of the genes that might be abnormal because we've removed or increased a copy, it might affect that balance of the vehicle moving. And so if we think about things that help keep our cells under control or the brake of our cells, those are known as tumor suppressor genes. And so sometimes when we look at these chromosomal abnormalities, we've removed a brake. And so then the accelerator is unchecked. And in some situations, we add another copy of an accelerator or something that is a growth signal. And then what we have is the brake is no longer able to balance that out. So these are the things that we have learned over time. So how does this relate to someone with chronic lymphocytic leukemia? Well, there are 4 different abnormalities that we test for: the 13q deletion, the 11q deletion, the 17p deletion, and the trisomy 12. And so what we are interested in is how does this inform the biology of the disease? And so the 13q deletion is very common. And what we're learning more and more about it is that it's considered a favorable prognostic marker, but it also might inform how people respond to certain therapies, specifically those that target the anti-apoptotic protein BCL2. And so that's important as we look at treatments such as venetoclax and how patients taking this drug might be affected by the presence of this deletion. And this is new information that we're learning. The 11q deletion was very important when we looked at patients receiving chemotherapy. But now as we're moving more away from chemotherapy, we're really learning to see whether or not this treatment option, this deletion really affects our treatment options moving forward. However, still relevant today is the 17p deletion. So this is the loss of the p53 gene, and really one of the breaks that is important in keeping that balance of cell survival and cell death in the CLL cells. And so patients with a 17p deletion may not respond very well to chemotherapy at all and should be receiving a novel agent. We're still learning the role about trisomy 12, and it might be amplifying some of the accelerator genes and may have a role in patients who progress to Richter's transformation. But the reality of the situation is, as we're not treating patients with multiple lines of chemotherapy anymore, we're seeing less and less of these severe cases, but it is still happening. So we're still trying to understand that biology. The important thing is these are tests that we often do prior to treatment for our patients, but not at diagnosis currently in the public healthcare system. So it is important that it changes. And so if you didn't have it when you were first treated and your treatment worked for a while and then you need to be retreated, it is important to test to make sure that you haven't developed some of these tests, these abnormalities with time. One of the things that has become important is that when we only do FISH testing, we might miss some people with the p53 abnormality. So now a lot of centers are starting to sequence this gene so that we don't miss a subset of 10% of patients that may have been missed if we only did FISH testing, so that they are treated with the best treatment possible. The other thing that really helps us to determine how patients are going to do on their treatments is the IGVH mutation status. So when we think of a B cell or a lymphocyte that is developing, it basically has to travel through the lymph node over time, and that's where it matures. So, and in order to mature, it ends up going through a rearrangement process because it's seen something in its development that helps it to mature and produce antibodies for future use. However, in CLL, what happens is there's a group of cells that go through that process, which are considered mutated cells, and there's a group of cells that don't. And so that group of cells that don't are called the unmutated cells, and they contain the ability to self-grow and have a lot of those immature components of a blood cell. And that allows them to grow quite quickly, and they may not respond to treatment as well. And so we have to select the treatment based on those factors. And so one of the things that we learned with chemotherapy when we were using it more frequently is patients with an unmutated IGVH were more likely to be treated. They also had a short response to chemotherapy, and it was very common in our treated patient populations. But if we look at CLL patients as a whole, prior to treatment, the majority actually have good risk IGVH mutation or a mutated immunoglobulin. And so what we need to do is in those patients with the unmutated IGVH, discuss with them what the best treatment options for them are given their poor response to chemotherapy. As we are introducing new treatments, targeted therapies to our patients, we tend to see less differences in the benefit patients gain, whether they're mutated or unmutated. So there's been a considerable change in the evolution of treatments with chronic lymphocytic leukemia. We moved away from chemotherapy to more novel agents and are looking at those in combination. So chemotherapy had its advantages and disadvantages. They were short courses of treatment, usually 6 months. They were cost-effective as treatment, and they were effective as treatment. People had lasting remissions with them. But they also had their disadvantages, the need to come into hospital, the intravenous components of the treatments. They were resource intensive for the healthcare system, and for the patient, they had a significant cost as well. The risk of infections, low blood counts, and lots of fatigue and tiredness associated with them. And most chemotherapy worked by basically attacking the DNA of of cancer cells. And so that meant that they were not specific to the cancer cells, and they could affect the DNA of multiple different cells. And so, these are things that were not as specific, worked in the time period where we had really no other options. And now we're starting to think more and more, is this the right treatment for all of our patients? So monoclonal antibodies are designer drugs, is what I call them. They're designed against a marker on the CLL cell, and they really work very well in combination with multiple types of treatments. But they really did make chemotherapeutic agents better because they enhanced the depth of remission, and people did really well with them. But we've really moved away from chemotherapy as standard of care, and we're really moving to targeted agents that really are important in the biology of CLL cell survival. So a lot of the common agents that are currently being used today or in clinical trials or have approval in Canada target the B cell receptor survival signaling pathway. And so commonly used are ibrutinib and acalabrutinib, but new on the market and coming to us in clinical trials are zanubrutinib and the Loxo compound. PI3 kinase inhibitors have been approved for CLL, but due to their side effect profile haven't been used much, but newer versions of these drugs are currently in clinical trials. But the main idea is that these are specific pathways that are upregulated in the cancer cells opposed to the normal cells. And so you're targeting the cancer cell specifically opposed to all cells. And then the other drugs that are really changing the way we treat CLL with targeted agents are the drugs that target BCL2 or venetoclax, the anti-death signal. And CLL cells have forgotten how to die, and apoptosis is the name given to that programmed cell death that is affected. And so this drug basically activates that process, leading the CLL cells to die. So what are the factors that are important in the treatment decisions? Molecular testing, as I mentioned. Then there's the patient-specific factors. So are you over the age of 65 or younger than the age of 65? Are you someone who is fit, i.e. you don't have very many medical problems? Or do you have lots of medical problems? Because all of those things need to be considered when we make that decision. And the types of medical problems that you have are also an important consideration because the side effects or some of the treatments. So it's important to note that CLL patients are older when they're diagnosed. The majority of them are over the age of 55, but the median age is 72. And about 89% of patients have another medical condition at diagnosis. And that this is a treatable condition, but is rarely curable because our curable treatments are often given after patients fail multiple lines of treatment and require intensive treatments with things like a bone marrow transplant. But with our novel treatments, we're really moving away from transplants as patients are able to do much better with some of the treatments we have available today. But these are things that we are constantly evaluating. When do we use them? And there's other novel treatments coming down the pipeline, such as CAR T therapy. So given this information, we want to find effective long-term disease control. We want to make sure we take your symptoms into consideration, and our goals of care really focused around improving quality of life and making whatever treatment decisions with you so that we are able to provide the best care and that you're able to tolerate the treatments or the interventions we have for you. And that's an important consideration. And so this is a figure that really just does demonstrate with our previous treatments. We used to have chemotherapies as single agents. We combined them with antibodies, and then we went to very intensive treatments combined with 3 different agents. And people could have remissions lasting from 1 year to 6 years or more. And they did really well if they could tolerate those treatments. But what we have here is the rates of side effects that required an intervention, i.e. a medical treatment or even hospitalization. And so the better those treatments were, the more likely you were to actually suffer one of these side effects. And so that's really made us think about, who benefits best from which treatments, and are there better treatments available for our patients? So the advantages of targeted therapies is that they're easier to take. A lot of them are oral and can be taken in your own home. There's less travel back and forth to the cancer center, but you still have to be monitored regularly. The disadvantages is that chemotherapy was a time-limited treatment option. These treatments currently have been designed to be taken, for the most part, every day until the disease progresses. They do have some predictable side effects, but also some unpredictable side effects. And they're very costly. Most of the costs are borne by your provinces. But they are still costly treatments. And we talked about the side effects already. So what are these side effects with some of these novel targeted agents? So when we are using these as single agents, some of the changes that we are often supervising you for are changes with your heart rhythm, the risk of bleeding. Some of the skin, nail, and hair changes were particular to first generation BTK inhibitors. These may be reduced with more specific BTK inhibitors, fluid retention, high blood pressure, and infections. The venetoclax as a single therapy is continuous, but we'll see in my next slides that we're starting to combine it with antibodies to actually give a time-limited option. But one of the most concerning features is when we start treatments with this is that it can break down the cancer cells very quickly, which can change parameters within your blood test. So it requires you to come in frequently for monitoring to make sure you're not undergoing something called tumor lysis syndrome. Some patients may also require hospitalization, depending on their institution's protocols. But for the most part, we in Canada have tried to adapt this to an outpatient treatment. So let's talk about some of the data that's exciting that has evolved over the course of the last few years. And so, comparing some of the standard treatments that have been traditionally available to what's new in CLL. So the ECOG 1912 is a study of young, fit patients who do not have high-risk molecular features. And this was a study that really compared ibrutinib to fludarabine, cyclophosphamide, and rituximab, known as FCR. And so what we have here are the data for the progression-free survival and the overall survival. And this was the first time a targeted agent given continuously demonstrated an overall survival advantage to standard chemotherapy in young, fit patients. Some of the data that has come up since then is that this is an effective treatment for patients with unmutated IGVH status, but in patients who have mutated IGVH, that FCR is still a reasonable treatment, and there's actually no difference in the progression-free survival in that patient population. When we look at fit older patients, so these are patients who were a little bit older than the patients less than 65, but still considered fit. But in this patient population, they did include 17p and 11q deleted patients. What we see here is the control arm was bendamustine and rituximab, which is the standard therapy, which was the standard therapy for this patient population. And this was a 3-arm study that looked at ibrutinib and rituximab, ibrutinib and bendamustine and rituximab. So I'm sorry, I may have failed to describe the graph in the last. So these are the percentage of patients who progress on the treatment. This is the number of months that it took for them to progress. We have to understand that bendamustine and rituximab was only given for 6 months. And so they maintained remission and then they started to progress over time. But what we see here is that patients with ibrutinib really are maintained on therapy over time and don't progress. So there was an advantage to this patient population as well. And so in patients with unmutated IGVH and high-risk features, we would offer this patient population ibrutinib as frontline therapy. So then what about the older patients? So in patients who would be considered unfit, we look at our treatment options. And so we looked at ibrutinib, a BTK inhibitor in the last two studies. This is a different BTK inhibitor known as acalabrutinib. And so acalabrutinib was compared to chlorambucil and obinutuzumab, which is the standard chemotherapy arm for the unfit population older than 65. And what we see here is it was also combined with another antibody known as obinutuzumab in the blue line. The red line here is acalabrutinib alone, and then this was the standard arm. And in this case, again, the acalabrutinib containing arms the acalabrutinib is continuous until patients progress on their from their treatment, and the chlorambucil obinutuzumab here was only given for 6 months. And so the majority of patients progress off treatment with the chlorambucil obinutuzumab, and those patients who received an acalabrutinib containing arm did really well. And when we look at that data 4 years later, that trend is still holding. So what we talked about right now was just continuous treatments, but not everybody really needs a continuous treatment. Maybe this is reserved for those patients with high-risk features. And so now we're looking at the evolution of time-limited treatment with novel agents. So the first study to do that in the frontline setting was the CLL-14 trial, and this is where they combined obinutuzumab, the monoclonal antibody against CD20, with venetoclax. And this is a time-limited treatment for 12 months. And in this study, they actually matched the standard arm where they got equivalent time of treatment, which is important. And they both stopped at the time period. And in this study, and there's also follow-up study that demonstrate that this trend continues even after 4 years, is that the venetoclax containing arm with the obinutuzumab results in a better progression-free survival than the standard arm with chlorambucil and obinutuzumab. And so this is now being made available to patients and will hopefully be funded in Canada in the near future. And so when I talk about high-risk patients, patients with 17p deletions really are the ones that don't really benefit from time-limited therapy. And this is the scenario where a BTK inhibitor, whether it's ibrutinib or acalabrutinib, which are currently available in Canada, are used opposed to patients who might receive time-limited treatment options, even with a novel agent. That being said, the unmutated IGVH status is really a discussion between you and your provider, your goals of care, and which treatment options are best suited for you. So a lot of these agents evolved because they were being used in the relapse situation. So we've known about ibrutinib and acalabrutinib in the relapse setting. And so here I demonstrated the frontline data, but we're now looking at time-limited treatments in the relapse setting. And so here we looked at venetoclax, which was given for 24 months and combined with rituximab for 6 cycles, and compared to chemotherapy, which was still given in patients who had a really long remission in the second line study, in the second line setting. And so what we see here is follow-up data demonstrating patients did really well when we stopped their treatments after 2 years. And so maybe not everybody needs a continuous treatment option. And this is, again, something that you would discuss with your provider, with your molecular risk factors, as well as your response to your previous treatments. But then we have to think about those people who are high risk and might actually benefit from a BTK inhibitor in the relapse setting. And so what's new and exciting is what we're learning about BTK inhibitors and their tolerability and their efficacy. So this is the first time there was a head-to-head study looking at ibrutinib versus acalabrutinib in the relapsed patient population. And this study only recruited high-risk patients who had at least had one line of treatment, but they had not seen venetoclax or a B-cell receptor signaling inhibitor. So this study recently reported at ASCO, and it basically showed that both drugs were equivalent with a progression-free survival of 38.4 months in both arms. But I think what was more important was the secondary analysis about some of the side effects that really do affect people's ability to stay on these treatments, and providers willing to prescribe the treatment because of some of the other medical conditions. And so atrial fibrillation was one of the main things that was evaluated. So we know that in patients who were receiving ibrutinib, there was a higher risk of atrial fibrillation, and this risk was reduced in the head-to-head study with acalabrutinib by about 50%. But there was no change in the risk of infections and no difference in the risk of Richter's transformation. The other thing that I think is important to note is other heart-related side effects. And so there are patients who have atrial fibrillation, but also high blood pressure or hypertension. And this risk was also reduced with acalabrutinib. Some of the nuisance bleeding and bruising was also reduced with acalabrutinib, but there was no differences in major bleeding. So that brings us to what are we doing in Canada today with treatment? So the standard of care for younger fit patients with low molecular risk is still FCR. For those that are not fit for FCR, there are a lot of different options that you would have to discuss with your provider, but this includes chemoimmunotherapy, venetoclax and obinutuzumab, and for high-risk patients, acalabrutinib or ibrutinib. In patients who are relapsed or who have had treatment before, then we move away from chemotherapy as any option and really look at new targeted agents. And the order of these targeted agents are dependent on what you received in the frontline setting. And obviously, we would encourage you to discuss the availability of clinical trials with your providers at any time point when treatment is required. So it's really important when we decide about our treatments for our patients, and some of those are based on the underlying medical conditions that treatments are based upon, because we're looking at the side effect profiles of our patients. We have to know that 40% of patients have high blood pressure and have other heart conditions. And so this needs to be taken into consideration when choosing treatments. And many patients with CLL have other medical conditions. And so we really are taking you into consideration as the patient when we decide what treatments we're selecting in partnership with you. So one of the things that we've learned is that continuous treatments have better efficacy, especially in that high-risk patient population, opposed to time-limited chemotherapy. But with new novel agents that we're combining and being able to stop treatment in is actually very exciting. And it's helping us to balance costs in patients. And these costs are not just financial, they're actually the side effect profiles that a lot of the patients are experiencing as well. And so, but one of the things that we're doing is actually moving our best treatments up front. And so what does that mean for the future for CLL patients? So what we're doing now is learning more about something called measurable residual disease or minimal residual disease. And this is the ability to detect 1 CLL cells and 10,000 CLL cells. And there's lots of different technologies that we're using, such as flow cytometry or sequencing, that are helping us understand this. And why is this important? This is important because we actually know that in patients who received FCR, if they had mutated CLL, they did really well. But what's important to know is if they had undetectable measurable residual disease, it was almost as if they were cured. So maybe this is something we need to work towards as we develop new treatments for CLL. So this is one of the key take-home messages. You know, I hesitate to say CLL is an incurable disease. We haven't figured out how to cure it with the treatments we have. So implementing measurable residual disease is starting to happen in Canada because we think this will offer patients a time-limited option. It will also potentially reduce the cost of continuous therapies, but it will also potentially limit what patients have to suffer and improve their quality of life based on the side effects that they are undergoing. And that allows us to potentially combine some of these novel agents to allow us to obtain a better depth of response and get to that point of undetectable, measurable residual disease. So one of the ways this is being studied is combining some of these novel agents, so venetoclax and ibrutinib. There's also studies combining venetoclax with acalabrutinib, and also studies combining these two classes of agents with an antibody such as obinutuzumab. And people are studying how best to use this. One is with fixed duration treatment, so it's just stopping after 12 months of these novel agents and learning about what happens. And other people are saying, well, if we have measurable residual disease, should we add another agent for a period of time and then evaluate again to see if we can get to the point where we potentially have cured patients? And so we're learning about this. This is an exciting phase. A lot of this is reporting at ASH in the next few days as well. And one of the things that I think I want to emphasize is why this is advantageous is that not does it only improve outcomes based on progression-free and overall survival, but we're learning more about genomic instability, which is the biology of the underlying genetics of your cancer. And maybe if we are able to eliminate the cancer cell compartment as a whole, then your disease may be stable longer, and we might not need to retreat you in the future. It also might help fight against the infections and the second cancers. And so this is a very exciting way of thinking about eradicating CLL and hopefully curing it. So overall, this is an exciting time for CLL, and we're working on better ways to improve the treatments that we provide you, eliminate the side effect toxicities that people are experiencing right now, and deliver better care for the future. So the future really does hold exciting multiple agent treatments that will allow us to help potentially have a cure for CLL in the future. And with that, I'd like to thank you and answer any questions.
Excellent. Thank you so much, Dr. Banerji. I was looking through a lot of the questions, so we do have quite a few that we've received. So it is now time for the Q&A period. And if you haven't already done so, then please be sure to use the Q&A box in your Zoom webinar panel to type your questions. We will do our best to get to as many questions as possible. Any questions that we do not answer, we will answer after the webinar. The community services managers will reach out to you directly. So let's get started. We did get quite a few questions ahead of time. I'm going to merge some of them to make this a little easier as well. So there's a lot of questions about watch and wait and when it's time to actually take action and how long is the average time that someone stays on watch and wait. So can you address that a little bit?
Yeah, so first thing is I like to use the term active observation opposed to watch and wait. I think it's better in terms of what we're really doing because we're really trying to make sure that you're not having any of the complications or symptoms. And that period is really variable based on every patient. Some of it's where your stage is in that early time period. So the earlier you are in your disease course, so RAI stage 0, 1, and 2 are often watched longer than those with RAI stage 3 and 4. And that really depends on each individual person. There's no really set time limit, but what we say to patients with earlier stage or low risk disease is that somewhere between 2 and 5 years can be up to 7 years, and those with more advanced stage disease, less than 2 years, but maybe up to 3 years.
Thank you. There was someone who asked for clarification. What does RAI stand for? I believe it was right before the slides on FISH.
So the RAI stage is actually named after Dr. Kanthi Rai, who was one of the founders and pioneers of CLL clinical care. So it's his last name. It doesn't stand for anything.
Thank you. There's a lot of questions about secondary cancer. So about, CLL progressing into Hodgkin's lymphoma or skin cancer. So can you maybe address that a little bit and, what are its...
So I will clarify that there is CLL that can transform to other blood cancers. So Hodgkin's disease is a common transformation that can occur, and diffuse large B-cell lymphoma. Sometimes people can just have simultaneous cancers that are completely unrelated. So it's not one evolving from the other, but Hodgkin's and diffuse large B-cell are common transformation cancers, but that is independent to what I would consider second malignancies. So second malignancies arise because of the immune dysfunction that occurs with chronic lymphocytic leukemia. So your immune system is very important in terms of being a manager of the cells in other tissues, and they get rid of cells that are not dividing well or dividing out of control. But with CLL present, the concern is that that's not occurring normally. And because that's not occurring normally, the abnormal cells can turn into cancer or develop into cancer in those tissues, whether it's the lung, the breast, the bowel. And so what I tell my patients and their primary care providers is the cancer screening is essential. So you need to go for your mammograms, you need to have your prostates checked, you need to do your colon screening and your cervix checks. Those are important things that you can do for yourself. And then from a skin protection, the second cancer rates for skin cancers are 4 times that in CLL and SLL patients, and even MBL patients compared to the general population. And so, we advise on sun health. So wearing long sleeve shirts, if you have something that you're concerned about, bring it to the attention of your family doctor, or if you have a dermatologist, have them look at it. And in part of my clinical practice, I evaluate the skin as part of my physical examination. And then sunscreen use is really important. So sun avoidance is also really important, and sun health.
Thank you so much. Quite a few questions about COVID vaccinations and efficiency or effectiveness, and also being more susceptible to viruses. So can you discuss that a little bit?
Absolutely. So this has been an unprecedented time in the last 2 years where we've had a lot of data come through specifically to our patient population. So what I can tell you based on data that's been published retrospectively in patients with CLL is the risk of COVID-19 is greater in patients who are immunocompromised at any point in time, including CLL patients. What we know about vaccinations in this patient population is not everyone responds to the vaccine in a similar way. Your best opportunities to respond to vaccination are prior to treatment or in remission. And so if a normal immune system has an antibody response of this much, a CLL patient is reduced significantly. And if you're on an active treatment with a novel agent such as a BTK inhibitor or a venetoclax, or have received an anti-20 agent within the last year, your antibody production is significantly reduced. And after 2 doses of the COVID-19 vaccine, we know that the antibody titers dwindle if you did have antibody production, and some people don't even mount a response. But we have learned with the 3rd dose that patients with CLL, 50% of those patients that didn't have any antibody production actually do produce antibodies. So my recommendation is that if possible, where you are, that all patients with CLL, MBL, and SLL are vaccinated with 2 doses at a minimum, and should be seeking the 3rd dose to complete their vaccinations. And I would not consider this a booster in this patient population, but a completion of their vaccination status.
Thank you so much for clarifying that. There's a question here. I would appreciate further information about the relationship between CLL and SLL.
Sure. So CLL and SLL really represent the same disease. I tell patients and other healthcare providers that this is really about geography and diagnostic criteria. So we're really splitting hairs. So if we look at the cell composition, it's actually the same cell. The same monoclonal cell is involved in SLL and CLL. The issue is in SLL is the white count doesn't meet, the lymphocyte count doesn't meet the threshold in the peripheral blood of 5 times 10 to the 9th clonal cells per liter. And that's why it's considered SLL, opposed to CLL, where you've met that threshold or surpassed it. So it's the same disease entity. It should be treated in a similar manner. Other than the geography in the bloodstream, that's really the only difference.
Thank you. When would it be appropriate for high-risk CLL patients to undertake Imbruvica or rituximab combination treatment?
So one of the figures that you can go back to is from the Alliance study. And so one of the things that was important is that rituximab doesn't add any benefit to ibrutinib. So the curves completely overlap. So in patients with high-risk disease, ibrutinib as a single agent is effective, and rituximab doesn't add any additional benefit.
Thank you. Is TP53 mutation tested outside of FISH or part of FISH?
Yeah, that's a great question. It's a separate test. So FISH really only tells you that a portion of the chromosome where P53 lives has been lost. It doesn't actually look at the sequence of the gene. So some patients who would have a normal FISH or haven't lost the 17p arm of their chromosome could still have a P53 mutation in the gene. So the only way to detect that is by sequencing that segment of the gene.
You. Do certain medications which are given for other medical condition exacerbate the chance of getting CLL or CLL symptoms?
So so as a whole, I would say no. I think that is not, there's no medications that could predispose to CLL specifically. However, patients who may be immunocompromised for other reasons can develop other blood cancers. And if they're on treatments that cause immunosuppression, they may develop blood cancers. Those are not commonly CLL, but in other conditions, other blood cancers may arise.
Sonia, your mic is closed.
Sorry about that. Thank you. So I have an interesting question here about if there's any research showing relationships of CLL incidence in agricultural areas in North America.
Yeah, that's a good question. So it's hard to know. There's no active research that I'm aware of. But one of the things that we wonder about familial CLL is that, you know, we haven't been able to identify a gene pattern of inheritance, but there's often families, about 10% of them, that are affected as families, but it's not like it's passed down from generation to generation. So the concern is, was there a common exposure? So Manitoba is obviously in an agricultural belt, but there's different immune diseases that run in these areas. And so we do have a high incidence of chronic lymphocytic leukemia, but we also have a high incidence of multiple sclerosis. So it's really hard to know whether or not the agricultural exposure alone is part of it, or is it viruses that affected kids when they were younger, or exposures in families that created an immune dysregulation. I think there's a lot of people trying to understand that, and epidemiologic studies trying to understand this, but the concern is association versus causality. So just because things are associated doesn't mean that they're causal. And so it's a very difficult question to answer because it might be associated with it, but not really causing it. And so it's something that people often talk about, pesticide, herbicide exposure, but then there's other cancers that can be associated with those more specifically, more acute leukemias opposed to the chronic ones.
Excellent, thank you. I think we have time for maybe 2 more questions. So this one here, what is Richter's transformation?
So Richter's transformation is the evolution of CLL clone into diffuse large B-cell lymphoma. And this is considered a transformation that can be quite aggressive. So diffuse large B-cell lymphoma is typically a curable high-grade cancer of the white blood cells. But in this case, when it evolves from CLL, it becomes difficult to treat and is often not curable.
There were a few questions concerning clinical studies and clinical trials. So maybe if you could just maybe address how CLL patient can actually access any clinical trials. And one specifically, are there any clinical studies regarding RR trisomy 12?
Like relapse refractory and trisomy 12?
Mm-hmm.
So I'll answer the broader question first. So at every center, at a lot of the academic centers, clinical trials are often available, but also community practices open clinical trials as well. So the way to seek clinical trials in your area is to find out at your cancer center what is available and open. And often your doctor, your specialist will hopefully approach you if they have one. If you don't have one, there is the possibility for you to potentially travel to a center to come onto a clinical trial, but that has to be discussed because not all people are reimbursed for those travel accommodations unless specifically allowed for in the study. So it can become difficult. So a lot of people are willing to travel to go to large centers across Canada or even to the United States to participate in the trial. But unfortunately, this can come with costs. So the best is to approach your local organization to see what is available for you. The second question that was asked was very specific. And the reality of the situation is right now, as standard of care on clinical trials, all these molecular tests are being done, and extended panels of sequencing of multiple genes, somewhere in the number of up to 300 genes, are also being evaluated in parallel. So I think we're going to learn more about what happens to patients with trisomy 12 in the relapse situation. We call them an intermediate risk because we are concerned that their prognosis might be different than someone with low risk CLL. But right now, specifically how they respond to treatment, specifically the novel treatments, is really being evaluated. And so we're going to learn. So every patient with that is allowed on a study. Typically, that isn't a reason for them not to be on a study, but they may not be randomized to a specific arm or stratified based on that abnormality because we're still learning about it.
Thank you so much. So if you don't mind changing the slide, actually.
Oh, sorry, yes.
Oh, that's fine.
I didn't know if I was still sharing.
So there were a lot of questions in the chat. There was a lot of comments, a lot of questions we received ahead of time. So my colleague Pascal had posted in the chat a way to contact the community services manager in your area. So our new website, bloodcancers.ca, you'll be able to find all that information there. Again, we will do our best to get to as many questions after the webinar. So anything that was sent.
Sorry.
Oh, that's all right. No worries. So the information is in the chat and it's also on your screen. So I want to remind everyone that we are here to help you. So do not hesitate to contact the LLSC. If you need more information or support, you can reach us by email at info@bloodcancers.ca. You can call toll free at 1-833-222-4884. And also, please check out our website, bloodcancers.ca, to learn more about upcoming webcasts, podcasts, or any special events. I'd like to note that a short survey will be sent to everyone who participated after this webcast. We greatly appreciate you taking a moment to fill it in, as it really helps us to offer you the most valuable information. And once again, thank you so much, Dr. Banerji, for being here today. Fantastic presentation. And
thank you very much for having me.
Excellent. You're always welcome to come present with us. From all of us at the LLSC, we wish you and yours a happy and safe holiday season. Thank you very much, everyone. Goodbye.
Right. Happy holidays.